This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Welcome back to episode 2 of this Artificial Intelligence in Nursing podcast. Let's get right back to it. In the previous episode, we were discussing various concepts related to artificial intelligence, machine learning, technology as an actor, and thinking about what's going on behind the scenes or what's going on in the box, so to speak, that we kind of take for granted or don't always understand. Let's see. We were going to jump to another term for Dr. McBride. What is augmented intelligence?
So augmented intelligence, you could go down a couple of different roads with that. Augmented intelligence is a subset of AI and machine learning, and it's designed to do exactly what it sounds like: augment or help support human intelligence. So augmented reality is a little different, where you actually are looking at three-dimensional space using digital technology integrated with real-world environments. So where we're seeing a lot of augmented reality is within training of physicians and nurses, where we can use some of these tools with special glasses, and the student may wear those glasses, but you're interacting with an environment that is could be like a human body, but you can actually go within that human body with dissection and anatomy and physiology.
Oh, okay.
And that's part of the augmented reality components of it.
Interesting. Okay. So there could be quite a bit of cost savings with that kind of tech.
Absolutely. Yes. More and more, we're seeing these types of tools used in simulated environments, and for that very reason. But it's also, not only is there cost savings, but you can do things in augmented reality that you couldn't do with a cadaver, for example. So, to take someone within the flow of the bloodstream and actually show how things are flowing within a body rather than dissection.
So cost savings, better learning, better training, all kinds of things. Okay. I read something interesting from an article in the Nursing Management Journal. It said that in 2019, the United States had an executive order called Maintaining American Leadership in Artificial Intelligence, which influenced the government to create objectives for speeding up AI research and progress. So how does something like that filter down to healthcare?
Well, first of all, health information technology is driven quite a bit by policy. And so more and more we are seeing that technology, policy, if we're going to compete with global powers in the world, we in the U.S. have got to be on top of things in terms of how we're using things like AI and machine learning and technologies. And so there has been a lot of focus in Washington, D.C., and I'm sure Kirk can probably speak to this as well with his policy work. But it's interesting, I think, there was an executive order under the Trump administration as well, very focused on this. And then prior to that, the Obama administration passed the 21st Century Cures Act with significant content addressing digital technologies and a focus on ethical considerations that always emerge when we start looking at these types of technologies. And so the Obama administration was largely a consumer privacy bill of rights also that was a comprehensive approach to protecting privacy, because as we use massive amounts of data, we have to consider all kinds of things. And so the focus now is actually on civil rights in the algorithmic age. And so under the current administration, they're focused on an AI Bill of Rights. But we also have the Food and Drug Administration, from a device management standpoint, stepping in to say, do we need to actually have these FDA approved AI algorithms and machine learning type technologies to where they're approved for safety? So all kinds of focus has been on these new and emerging technologies and how they will be introduced in our daily lives from a civil rights standpoint, but also, safety from a clinical safety.
I'd love to hear more. You mentioned the ethics and civil rights. I'd love to hear more about that. What do you see as concepts related to the ethical discussion? Like off the top of my head, I'm thinking maybe consent-related matters, privacy issues, I guess what data people or organizations have access to and can they share it? So tell us more about that, the ethics.
Transparency, but we also have whether we're biasing the algorithms. So
Okay.
it takes data to actually, big data, to feed these algorithms. For example, a lot of our genetic research historically has been white, Caucasian, European descent individuals. So we biased a lot of the science, and now what we're trying to do is balance some of that with National Institute of Health initiatives like the All of Us program. And the All of Us program is all about getting data from individuals who are minorities and other, not white, Caucasian, European descent, so that our algorithms from a genetics and genomics standpoint are truly working for everyone. And historically, they've been biased. And so that's an example of a very significant ethical issue. And in fact, as we as researchers approach the All of Us data, or we encourage individuals to contribute their data to this, we are bound by all kinds of ethical principles that are way above and beyond normally what we would do with typical research. I like to call it the institutional review board on steroids, because it's paramount that we protect individuals' privacy, security, but at the same time, we have unbiased data that will feed these algorithms. So those are some examples of some of the significant issues that we're confronting now.
Okay, let's talk more about that. You already told us about some algorithms in episode 1, but tell us more about this and what you were just talking about with can there be bias there and what we can do about it?
Well, if you think in terms of how these algorithms work, and they're triggering clinicians to do the right thing at the right time for the right patient, and you've biased an algorithm, and oh, by the way, it's a black box phenomenon, so it's not transparent, and you don't know what's behind the algorithm.
Okay.
It may not work for you at all. And so clinicians may, like Kirk, may see, wow, that just doesn't seem like it's right. The scenario that we gave in episode 1, where we were talking about the patient that actually had heart failure, and it was triggering like it was a sepsis or a bad infection.
Right.
So it was confused, or it didn't, it could have gone down either path, and those algorithms will make a decision for you. And then you as a clinician have got to say, I don't think that's right, or perhaps it's not. And so in some scenarios where it could be gray with even making a diagnosis of the patient, and then you get the computer telling you, go this direction, it becomes, you get all kinds of ethical considerations there too, and legal issues. Because what if I make the wrong decision and the computer told me to go down that path, but I thought it was, I didn't think it was heart failure. I thought it was sepsis. So and then you have the computer also with the algorithm that's fired. So there are just all kinds of considerations that we have to consider with these algorithms, such as that. And I'm sure Kurt may have some things to add to that as well.
Oh, for sure. Yes, this sounds like something Kirk's going to be able to talk about a lot. Before we get there, okay, I'm just thinking. We have the data that we enter into the computer or the software. What about unintentional errors? Like, let's say we accidentally type the wrong thing, or we click the wrong thing, but yet that's input that we're giving, right? So are there any, I don't know, are there ways, is there things built into the system to kind of compensate for when we're inputting data, but we are humans and we accidentally enter the wrong data, but yet it's having an effect?
Well, I think you're getting to the integrity of data is critical for these algorithms, because that's the other way we may unintentionally bias the algorithm is with erroneous data.
Okay.
And so we have an old adage, garbage in, garbage out, with analytics, that many times the data, especially that we get out of the electronic health record, where we're capturing it, and it may not be captured in a standardized way or as structured as we want it to be, or we have an open-ended text box and we're typing in, and or we may omit information or data. There may be a lot of missing data. So these algorithms are going to do the best they have with what they've got. And if there is dirty data in the system, it could very well take us down a path that we might not want to go down. It's one thing that I think is critical for clinicians to understand is the importance of the clinical documentation and how it is being used to actually detect things that feed a lot of these AI machine learning, and even our retrospective analyses that we do from our electronic health records, where we use the retrospective data to build the algorithms. And that is how they're developed many times, is we'll have something called a training data set, where we build the algorithm with the one data set, and then we test it with another data set. So they're built retrospectively. And if you have omitted, dirty, or missing data, you really can't go back and correct that. You use what you have.
Okay, and one more thing before we turn the mic over to Kirk. There was an example you had where there was some research involving COVID-19 or something, and you said some nursing informatics professionals were able to interpret or analyze the data and find out what was really going on. I think that's good to talk about that example here.
We've had a lot of use of AI and machine learning with COVID-19 globally. And so there are volumes and volumes of data globally of what's happening with COVID-19. And then right down to the block level, we have used AI and machine learning to determine where is it that we are seeing patients that are hotspots of infection, and how would we prioritize getting those patients into the hospital or clinic first, because we know the likelihood or the odds of probability that they are going to be infected is higher than other areas of a geographic region. So that is one example of how we could use these algorithms to detect what's happening in public health. And so we're doing a lot in public health informatics with these types of algorithms. And so an epidemiologist will tell you, done right, we have the ability to identify earlier, inform earlier, isolate earlier, and perform functions that we need to do at a local level, especially with something like the COVID-19 pandemic.
So let's say there's, a majority of females in the nursing profession, not all areas of nursing, but overall. Like if you were doing research, you could mistakenly attribute some of the findings to a certain reason, but it really has to do with the sum total. Your set had to do with the fact that there were a majority of women employed.
Yeah, so that's an example that I often give. We worked with a healthcare system with massive amounts of data. And this was actually early on when we were working with a neural net. And we were trying to actually determine whether or not this neural net would work for our healthcare system. And we tested it with a large data set. And the data scientists came back with this wonderful aha moment that they had one particular hospital who was seeing a large majority of females. Well, it took us 2 seconds to realize that was a women's and children's hospital where they delivered babies.
Okay.
And so it was a large proportion of women, yes. But I think it's kind of a silly example, but the important thing is that knowledge workers and people that understand the data and where it's coming from and a lot of detail about the clinical scenario from a subject matter expert, that the data scientists must work with clinicians and people that understand the data, or you're going to get wrong answers. And so there are several scenarios where we have data scientist teams that have created algorithms and they're off. And our nursing informatics specialists often play roles to say, yes, but did you think about using these data, or adding this variable into your equation here, this whole area of perioperative data, for example, on an OR patient that you neglected to include might help you predict what you're trying to predict. So those are the types of things that knowledge workers or subject matter experts and clinicians can help teams of scientists with creating algorithms that work more effectively in healthcare.
Okay, well, let's turn the mic over to Kirk Ornstein here to tell us about information to consider around clinical scenarios with AI and insulin pumps, insulin administration, blood glucose monitoring overall. So we know AI has enabled some technological advances in monitoring and medication delivery. So for example, insulin pumps for patients with type 1 diabetes have begun using AI and algorithms to dose insulin. However, in my communicating with Kirk, we've learned it's not as easy a concept as program it and forget it. Patients and healthcare personnel still need to monitor themselves and their patients, and there's a learning curve. So, Kirk, please tell us about the convenience, but also some of the dangers of some of this technology with regard to AI and this concept of the technology is managing the patient's condition.
Exactly. That's sort of what we're dealing with the technology managing the condition. So my experience with the AI is sort of a brand new thing. My experience has come through insulin pumps and dealing with type 1 diabetics, mostly pediatrics. And the introduction to AI into the insulin pumps really started this year with the rollout of some new insulin pumps that were infused with AI, which, and I say it that way because as the nurse who's managing it, we weren't really aware of what that meant. The idea that that the insulin pump was going to help you make decisions sounded great. The idea that we were going to be able to manage blood sugar better, more incrementally, more micro dosing, sounds like a fantastic idea. But what we found was that I think two things. One was, like you said, the black box. We couldn't see what was actually going on. And the other was that we didn't really know how to interact with the AI itself. So for us, we're used to a heart rate's a heart rate, an O2 sat's an O2 sat, respiration rate, just it's straight data. And what we sort of found that we were getting was more of a summary, like everything's good here, blood sugar trend's okay, you're good to go.
Okay.
And because we didn't have that training of how to interact with the AI, it put us in a position where we weren't seeing the real data. And so we started trusting, without even knowing it, started trusting the information we were getting without any real critical thinking.
I like what you said. I want to highlight what you said. You didn't have the training to know how to interact with the AI. That's very good. What do you think about that, Dr. McBride? That's a good way to put it, right?
Absolutely. I think it is. And it's what we as nursing educators are up against. We have so much that we're training these young professional entry-level graduate nurses with clinical. And then we complicated it with electronic health records. And now we're adding, and just an infusion pump, is a tough piece of equipment to really, and of course there's different infusion pumps. So one infusion pump is the next infusion pump. And now we couple AI and machine learning with a lot of all of it. And we are accountable and responsible for a lot.
Yeah.
And so I think buyer beware is maybe the biggest, if it doesn't, what I always tell clinicians, if data and information or technology doesn't look right, suspect that it's not right and act accordingly, because so often, especially the more expert we get on a novice to expert level of training, we just intuitively know it's not right. Something's not right. And just like we can look at a patient, and Kirk's, I think that you are likely in agreement with me, that we can look at a patient and just know, ooh, that patient is about to go south. And same thing, we need to get to the point where we can look at that technology and go, ooh, something's not right. And I don't know, Kurt, has that ever been your experience with any of these technologies, that your intuition's telling you, oh, something's not right?
Oh, absolutely. There are times, and it came a little bit later as we're dealing with the AI, that, that critical thinking that all of a sudden we sort of drop needs to come back into it, that all of a sudden we were getting notifications that didn't make sense. And so I found myself going back to some very basic stuff about how to manage blood sugar. I'm going back to the orders and the ratios and things like that, and trying to figure out what the bolus should really be and not what the AI is telling me it should be, because the numbers didn't look right. Even as the AI is telling me something else, you have to step back and look at the bigger picture and really what's going on, and then dig into the AI and see what is it really doing. We would have to go in, I would go in and go into the background information and see what it was really dosing. And then from that dose, plus what it was reading, plus what I knew as the clinical orders, you piece together the right thing to do.
You're making a really good point. And so coupled with all of this technology is the ability to evaluate it and validate it. Because once we plug these algorithms in, a whole nother ethical consideration is maintenance of them. And so because they worked one day doesn't mean a year from now these algorithms are still going to work for us, especially if your patient population has shifted and changed. Even at a population level, much less individual patients like Kirk is describing. But he's also pointing to something that's really important. When these algorithms are out there and they've been triggered, you can back into looking at whether or not they're doing the right thing at the right time for the right patient. But it's very complicated data analyses to actually look at, okay, the algorithm said to do this, but we should have given all the characteristics and all the details of the patient at that point in time, blood sugars at this point, we should have done this. And so I've seen this done with things like sepsis, where you're getting these sepsis triggers like we've talked about in this series, and you can back into it, sepsis. Was it sepsis or was it not sepsis? And then, so you can determine on a population level. But when Kirk's pointing to an individual level of a patient at any given moment in time, when you've got all of these different factors that are influencing that dosage, that analysis is a big data science challenge in and of itself to know whether these algorithms are working right.
The other part is that there's an expectation that we're going to feed some of that information in as well. And I can say that there were times, based on how, in this case of, say, hypoglycemic patient, you're supposed to give 15 grams carbs over 15 minutes, that kind of thing. But because it doesn't involve any insulin, potentially doesn't get fed back into the insulin pump where the AI is. And so now it will view the blood sugar change as some sort of baseline change and not as a result of a carbohydrate infusion. And so now what we've done isn't really calculated or evaluated by the AI as something other than baseline based on who knows, I don't know, because it's the algorithm. And so the information it's getting is no longer right, because one, we don't really know that we need to do that, and two, there's really not a placeholder for us or for it to do it. So it gets a little messy when we're trying to feed back information in that it might need to make those future decisions.
Interesting.
We found that out later when we're like, wait, there's a piece missing here. And then we realized that might be going on. But again, we didn't really, there's nowhere to go to say this is the right thing to do. It just becomes part of that critical thinking. Well, if it's spitting out information based on this and we're doing something and the AI doesn't know we're doing it, well, there's clearly a disconnect there that's going to have an effect. What effect it might have, we don't really know, other than it's data it should have, and we're not giving it to the AI. We fall back on that critical thinking because it's all about patient safety. And so you see something that doesn't make sense, you respond and act. But again, you want to think you're working with the AI, but a lot of times it feels like you're working against it, or definitely not in cooperation or any other way. And it sort of becomes this bumpy ride trying to figure out how to get to where you need to be.
Right. So I guess we'd want perfect or ideal collaboration, but sometimes it can be working in spite of it, or there's two parties involved, and one doesn't always know what the other one's doing.
Well, I think one of the things that we've seen with, say, the parents of the patients, there's an expectation of being perfect, that now that we have this technology and we can make these, for my case, the blood sugar is much more narrow, then there's an expectation that we should be able to do it. And that further complicates things when you have so much information and the expectations start to rise. Getting there can be difficult.
Okay, well, let's go ahead and wrap up episode 2, and we will come right back and continue. And I think Kirk's going to tell us about some more of the impact of AI and then some patient experiences. So stay tuned.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.